Welcome. Welcome, everyone, to the International Foundation for Integrated Care, IFIC Canada, quarterly virtual community event. People are signing in fast and furious. Today, we're going to be talking about how does policy support integrated care with international examples and also a Canadian example with Ontario practice being highlighted. Yink, if you go to the next slide, we can just let people know that you should use the chat box to introduce yourself and also to ask questions, contribute your thoughts, contributions, other references that you have throughout the entire session today. Please be sure that when you look at that chat box, it says to all participants and attendees, or to everyone as it may be, as it appears. So please type in into the chat who you are and where you're joining us from. Feel free to share on social media as well. Let us know who you are and where you're joining us from. I'm sure this is going to come alive. There we are. Amber Alpach Bishop opening us up from London, Ontario. Paul Wanka joining us from Montreal. Matt Jones from Care for Health in Ottawa. Craig from Peterborough in Ontario. Melanie from Kenora. A pleasure. And we have Karen Kranick, Dr. Karen Kranick from Toronto. We have Nancy Hooper from Barrie. We have Carolyn Steele-Gray joining us from Toronto. Welcome, Carolyn. Kim Elke from Kenora as well. In the north, for those people who are not from Ontario, that is far northern reaches of our province. I'm really happy to have you joining us today. Kelly Kay from the Provincial Geriatrics Leadership Office. We have Catherine Wynn from the Center for Research on Integrated Care and the University of New Brunswick, St. John. Welcome, Catherine. We're very, very pleased to have people joining us from across Canada. And I do know that we have many signed up from Alberta and other provinces as well. So looking forward to seeing them signing in. Welcome, Care Partners in Southwest Ontario. Jennifer from Empowered Kids Ontario. And there's some acknowledgements there also around treaty lands. Sharon Anderson from Alberta. Welcome, Sharon. Sharon, very importantly, leads Care Partners or Care for Caregivers Canada. Sharon, you're going to put that in the chat. But we are going to have a session on National Caregivers Day on April 2nd, co-facilitated by Sharon Anderson and colleagues in Alberta, as well as our Carrie Koleski from the IFIC Canada as well. So looking really forward to April 2nd. You can put that in your calendars. I see that some others have already acknowledged the land. I'm coming to you today from the University of Toronto in Toronto, Ontario, and I acknowledge that the land from which I'm hosting this meeting is the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat. Also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit and the Treaty of the Dish with One Spoon. We acknowledge that Canada, across Canada, is home to many diverse First Nations, Inuit and Métis people, and each of you are joining us from one of these many traditional and treaty territories. I'm grateful to be able to come together today in this virtual environment, in this virtual platform. Welcome, and I'm here today co-hosting on behalf of my co-director of the International Foundation for Integrated Care Canada, Jodine Goldhar, who has joined us on many sessions and will be joining us again in the future. Today we have an all-star lineup, and all of our work is supported by colleagues, IFIC Canada, Yinka McCauley, the HSPN, Tricia Martin, as well as IFIC, Niamh Daly-Day, and Fiona Line, also joining us here today. We'd like to know if this is your first time joining the IFIC Canada virtual community. So why don't we'll put this up on a poll, and then you can click in, and please continue to introduce yourself. I see Susan Joyce from North Toronto, Rhonda Schwartz from Central East Ontario, and Simcoe Muskoka. Natalie, welcome. Continue to let us know who you are and where you're from in the chat. And this way, because we can't see each other all, it's a great way to know who is participating. Thank you very much. And just remember to be sure that you're putting in that the 2 is to everyone when you are typing in the chat today. So if you can answer the poll, many people have responded. A few more just clicking in. And I think we will close it off here. And we can show off those poll results. And we can see now that we have 40% are joining for the first time. To me, I say that people come for the content. So if it's your first time joining, there must be something about understanding the policy context and supports for integrated care and the international examples that has brought you here today. Welcome. I think that you're going to have lots of information shared with you today. And for those that it's not your first time, 60% of you are back again. Welcome back. And I think we have a wonderful event planned today with lots of really exciting information coming your way. I've had a chance to preview some of it. I'd just like to let you know that IFIC Canada has been on this journey for quite a period of time. We inaugurated in 2018, and we first hosted the NACIC virtual conference in 2021. And we've been continuing to build capacity. We've now created a center for integrated care at the University of Toronto as well. We'll have to link up with our colleagues, I know McMaster and now New Brunswick as well. So these centers are cropping up. We have also created one at the University of Toronto here. And very excitingly, we'd like to make sure that everybody here, if Inka, you can go next, that we have our next big event coming. This is the North American Conference on Integrated Care, the second one. This one will be in person. We are hosting this in Calgary, Canada, this year, this October, from the 15th to 17th. Start planning. We had another planning meeting this morning, and the call for abstracts is coming out in the next week or two, I'd say. And so watch for that, watch for the registration that's coming up. And our overall focus is really on creating health and well-being through integrated care, connecting the tissues of integrated care efforts across this entire country, supporting from community strengths and broad engagement and participation. And you'll see a really strong flavor around that in the conference themes that you see coming ahead. To stay informed, to make sure that you're knowing about these events and other events that are coming up, please sign up for the IFIC Canada newsletter. And there's a QR code there to do so. And you can also search for the International Foundation for Integrated Care Canada, where you'll find it on the website. You'll see that sign up form is generic across all of the hubs. So you can actually have an opportunity to sign up for other countries' newsletters as well. But certainly be sure to click the box that says IFIC Canada. I see people are still joining in. Welcome, Patrick from St. Vincent's University in Dublin, Ireland. I'm looking forward to coming to Ireland later this spring for the next international conference. So as I said today, we have lots to learn. First on policy supports for integrated care from 4 jurisdictions, and this has been a policy analysis of Germany, England, the Netherlands, and the United States. It covers topics such as legislation, accountability, financing, and some of how those are being put in place. You know, one of the big learnings for me from this project has been improvements in data, policy entrepreneurs, and implementation supports being critical enablers. So today, I think you will hear from many of the speakers, and really very much invite all of the participants today to talk about that implementation supports at the front lines, supported by policy and how that gets put in place. We have an international informant panel. I'll introduce those folks in just a moment, who are also going to contribute from their many decades of experience in this space. And finally, we'll come to a Canadian example with Ontario Health Teams, where we've done a deep dive to understand the challenges faced by Ontario Health Teams and the policy stakeholders in advancing the OHT model through such strategies as setting direction, understanding transformation levers, balancing local priorities and standards, funding and system roles, as well as relationships. So really a lot to be covered today. Next slide. Today's speakers from the North American Observatory, we have Sarah Allen, who's the director, as well as Stephanie Tam, who's a postdoctoral fellow at the Institute for Health Policy Management and Evaluation and the North American Observatory. And Sarah will introduce the NAO, and Stephanie will talk about that international jurisdiction work that they undertook over the past year. Camille Ung from the Nuffield Trust and Victoria Stein are our international panel. I'll introduce them a tiny bit more when their time comes. And finally, our own Dr. Gayam Boldania, who has undertaken the local policy analysis. So I am going to have one quick poll before we go off, and that is our foundational. We'll come back to this later to understand how knowledgeable our participants are today about policy supports for integrated care in other countries. So you have different levels you can enter, from being not knowledgeable at all to somewhat knowledgeable, and maybe there are a few experts out in the audience today. So let us know where you are, and we have over 150 people joined us so far today, so really looking forward to an active discussion in the chat. And I see also Sharon, thank you very much for adding in that info for what is coming up on our April 2nd virtual community event. And we have over 2/3 have responded into this poll. We'll give it about another 5 seconds. People are much quicker on this than they were in our early days. We've been doing these virtual events since 2019. So for a whole year, actually, before people turned virtual in the pandemic. Okay, let's share the poll results back out, and we can have a sense now. Might have to scroll a little bit to see all of the results. But we can see actually that there's a smattering of knowledge, but mostly across the lower ends, with about 20% not knowledgeable at all, or just barely a little bit of knowledge. And so I think today we're going to see quite a bit of valuable information coming your way from understanding this. And we're going to start that off with our colleagues at the NAO, introducing Dr. Sarah Allen, who's my colleague here at the University of Toronto. And so on to you, Sarah. I'm pretty sure that here we go. Thank you very much.
Thanks so much, Walter, for the invitation to present this work that we've been really, pleased to have the opportunity to work on over the last year. And so I'm just here to introduce the NAO and the team, and then I'll hand it over to Stephanie to present some of the findings and high-level sort of insights that we were able to learn before we hear directly from experts themselves from their own countries. So I'm Sarah Allen. I'm Associate Professor at the Institute of Health Policy Management Evaluation at the University of Toronto, a colleague of Walter's. I'm also the director of the North American Observatory on Health Systems and Policies, and that's a research center and collaborative network. So while we have a base in the University of Toronto, we have collaborators and colleagues across Canada, across the United States and Mexico, and we routinely conduct comparative analyses of pressing health policy challenges within Canada at the subnational jurisdiction level, but also across comparators that are often compared to Canada and Europe, Australia, New Zealand, and across North America. And so in that spirit, we're here to present some of the work that we've been engaged in over the past few months to really understand what we can learn from other jurisdictions that have had similar aims and objectives to what we have across Canada to improve integration, but have a bit more experience, several more years of experience. And so cautionary tales, lessons learned on what has worked and what has not worked is sort of the thrust of this project. And I'm joined by Stephanie and Julie, who really led this work. And so on the next slide, I'll just acknowledge that we were extremely grateful that people were willing to spend time with us, because this was really a combination of relying on published literature, but really learning directly from experienced individuals. And we're really pleased to have had the opportunity to do this work thanks to the support from the Health System Performance Network. And our team is here for the whole webinar, and please send your comments and questions on the chat. We're also happy to take any questions or comments via email, and happy to share some of our other work at the NAO, both comparative health systems and policy research within Canada's provinces, but across countries. So I'll turn it over to Dr. Stephanie Tan, who's going to lead us through a sort of 10-minute overview of the results, and then look forward to the discussion today. Thanks again.
All right. Well, thank you so much for that introduction, and to IFIC and HSBN for having us here today. To begin with, I want to provide an overview of our study. So Sarah's already prefaced it with where the objectives are. So I'm just going to briefly go over our methods and a bit of what we and then into our finding. So we conducted a literature reviews to start this off and to identify innovative models of care occurring in these 4 countries. And we held semi-structured interviews with 16 informants from our 4 jurisdictions over the summer and fall of 2023. These interviews allowed us to validate and expand on the learning from the literature review to identify promising policy supports for the implementation of different types of integrated care models of care across Canada. Can I have the next slide, please? Thank you. So across our 4 international case studies, we find that all jurisdictions are pursuing greater coordination or integration of care to improve care effectiveness and efficiency for patients. This slide provides some context about the reforms in each of the 4 countries that we examined in our study. First off, in England, there has been a focus on devolving decision-making to foster more locally grown policy development through legislative reforms and a series of overlapping pilots for integrated care. These have been intended to promote local decision makers to become more responsive to the population, but they have struggled against wider and often competing pressures for austerity in public services. Similarly, in Germany, we find there's experimentation with different population level approaches throughout the country. For example, in the Black Forest, there were selective integrated care contracts between health insurance funds and providers to generate share savings. There's also interesting experimentation through the health kiosk approach, which is a local spot to access health and social services support, particularly in underserved areas. So we see this in a socially deprived district of Hamburg, and also it's currently being trialed in Cologne. In the Netherlands, we find there are several financing and workforce tools in use as policy levers to pursue more integrated care pathways. These are largely at the subpopulation level, such as local neighborhood teams in The Hague, addressing chronic conditions through disease management programs, or targeted interventions at maternity care. In the United States, we find that accountable care organizations focus on better connecting primary care providers through community, primary, and allied health professionals by drawing on legislative supports and requiring ongoing evaluation as an accountability mechanism. Next slide, please, Inka. Great. So the first of the 5 policy supports I'll be discussing today is that of governance and partnerships. Across all jurisdictions, we find legislative reforms are important in enabling new partnerships or service innovations, but policymakers can further facilitate this process by setting out guidelines or expectations about how actors at all levels can practically collaborate across healthcare and the social and community care sectors. They can do so by setting out clear objectives, which can be aligned throughout the implementation process, for example, by setting out clear logic models. We also find it's helpful to identify and empower local policy entrepreneurs. For those not familiar with the term, policy entrepreneurs refers to actors that are inside or outside of government that can take advantage of policy windows to put issues on the political agenda. Our informants identified specific individuals as policy entrepreneurs in England and in Germany that brought about innovative ideas and drew together necessary actors to enable the policy process in a top-down or in a bottom-up implementation way. It should be noted, however, that the policy processes that are often credited to specific policy entrepreneurs can encounter issues later on when trying to scale or replicate a project outside that initial site. This can apply both domestically and internationally. Thank you. Next, we'll discuss the role of financing as our second policy forward. Across all jurisdictions, we see a range of initiatives to align financing, such as aligned purchasing, pooled budgets, or pilots. From England, we find evidence from the evaluation of the Better Care Fund that pooled budgets did work to enable joint decision-making and better coordination of care. However, it should be noted that this is a very small-scale example, but informants reported it better facilitate better collaboration when sites overlap with other concurrent pilots, such as the Vanguard New Care models or the Integrated Care Pioneers. From the literature, we find that bundled payments in the Netherlands or disease management programs in Germany are quite widely discussed, but several expert informants said that these disease-specific financing streams can be insufficient to overcome fragmentation within the health system and could even exacerbate it. Instead, they suggested the policy should focus on reforms for systems of care and better coordination. Lastly, in financing, new pilot initiatives are very welcome because they enable experimentation with innovative new models of care. But it's also important to have a plan for continued funding or practical support for successful pilots. For example, we find that the German Innovation Fund is a really interesting example where pilot funds include a requirement for a program of evaluation as a mechanism to extend funding for successful projects rather than having them end at the end of a set period of time and have a lot of that policy learning not go forward or be applied further. Next slide, please. Thank you. Our next policy support is that of workforce and staffing. We find evidence across the European comparators that dedicated funds that can contribute to bring on a new individual, for care coordinators, or an embedded researcher to act as a knowledge worker was really important. Informants we spoke to describe knowledge workers as individuals responsible for communicating about or facilitating new models on the ground. Second, informants in multiple jurisdictions said it was important to have a physical space available for training or meetings to enable collaboration between partners in the health or social sector. Informants said it was important to have a place to meet that wasn't necessarily on health territory to discuss how collaboration could be improved or how patients needing coordinated care plans could proceed. Our informants actually noted that virtual options during COVID-19 pandemic seemed to even the playing field to facilitate more distribution, to facilitate what felt like a more equal distribution of power between the sectors, so that there were several examples, so that meetings were no longer 10 or 30 people crammed into a single clinical room trying to see one laptop, which is a handful of people from the social or community sector. Next slide. Yeah. The next policy support for discussion is that of data sharing and use. This remains a significant issue for policy implementation across all jurisdictions. For example, our informants reported issues with data sharing across primary, secondary, and community care, especially where systems couldn't share information across settings with ease because they were using different electronic medical systems or records. And sometimes there was quite mundane barriers such as metric system incompatibility with a community care setting using grams while a secondary care setting used kilograms, so that you had to input data again. The other points on this slide, I'm going to touch on in more detail in our policy challenges. So next slide, please. Thank you. Our last policy support is that of equity initiatives. Across all jurisdictions, we find strong interest in addressing socioeconomic or racial inequalities at the national level, but in practice, projects are often locally determined and vary tremendously in scale and scope. We argue that policymakers do play a really important role in setting the agenda for equity-deserving initiatives, but could do more to support implementation by outlining necessary steps or a timeframe for those initiatives to proceed. Next slide, please. Thank you. So overall, we find there are a range of policy supports in practice, but we want to highlight four key challenges to policy implementation before we move into our policy implications. So first, we find across all jurisdictions that there are entrenched power disparities between the health and social care sectors that pose significant challenges to achieving meaningful integration at scale. Integrated care initiatives have to consider existing power relationships between sectors and institutions, as well as their values and interests. Our key informants told us that power imbalances between hospitals and community providers could really impact the success of integrated care initiatives, particularly because they tend to focus on driving care outside of hospitals into community. So there can often be less buy-in from hospitals to participate in such initiatives. However, the Netherlands offered an interesting counterexample where they addressed this imbalance by moving long-term care within health insurance packages rather than leaving it as a responsibility for local municipalities. Second, informants emphasize the importance of monitoring and evaluation of integration initiatives. Often there's a reliance on proxy measures, such as emergency department usage, because there are no clear established measures for assessing integration success. So all jurisdictions have struggled to qualify progress beyond unplanned emergency department use or shared savings amounts. So more accountability mechanisms or requirements for community engagements or the appropriate use of clinical audits for new pathways of care can have the potential to foster the development and of evidence and better data use to validate both successes and failures. Third, data sharing and use remains a persistent challenge across all jurisdictions, particularly in our European comparators. These range from practical issues of data compatibility to more serious issues regarding data transparency and the ability to share data for robust or independent valuation for pilot initiatives. Lastly, policy transfer of successful models of care between and within jurisdiction is harder than it seems. It's really important from informants and our analysis that to focus on both successful support, such as the role of knowledge brokers and care coordinators, and to enable appropriate funding to allow them to support implementation and scaling if that is the goal. But informants also suggest that we should focus equally on failures alongside successes, draw out lessons for other jurisdictions so that failure isn't put in silo or seen as a negative. There can be policy learning from both ends. So just next slide, please. So overall, to close out, I want to draw out some key learnings from our work to identify some potential insights. Given the time constraints, I'm only going to draw out 2 of these. But first, we find that legislative reforms do enable the development of partnerships at the macro level, but policymakers can further support this process of implementation. So they can do so through the development of logic models to clearly set out how new models of care can be actualized and what people in the system can actually practically do at each level of service delivery to enable the implementations of these new models of care. And second, policy guidance for integration really focuses on the importance of interdisciplinary teams and collaboration, but there were quite limited examples of support for actual workforce improvements, such as funds for dedicated staff members, overseeing projects, or project managers, or dedicated meeting space. Where these did occur, informants knows that these really were able to facilitate and manage implementation alongside success. So thank you for your time today, and I welcome further comments or questions during our panel today.
Oh, thank you so much, Sarah and Stephanie, for sharing with us the results of that review. And we're going to come back to have you join our panel. And we have some questions that are coming into the chat now. I look forward to having a bit of a discussion around some of those. I also found the topic of policy entrepreneurs very interesting. And I think that there is a role around bringing evidence to practice and having champions at the forefront of all of this work. We now have a couple of international experts in this area that we had been consulting amongst the others in this work around the NAO's report. And we are very fortunate for those who are familiar with the Nuffield Trust, one of the think tanks in the UK, out of England, that has done a lot of work over the years in understanding the policy environment and supports for integrating care and for other advances towards population health management. Camille Ung is a fellow and has much experience in the NHS and outside over the past 20 years in the UK, and will bring that expertise. Then Victoria Stein, who is co-founder and co-CEO of VM Partners, has had a lead role in the International Foundation for Integrated Care over many years, and is currently the co-editor of our premier journal in the field of the International Journal for Integrated Care. So we have 2 really brilliant experts to hear from, and then we'll come back to this in a discussion along with Stephanie and Sarah around some of these international implications. Camille, let me turn it over to you first.
Thanks very much, Walter, and hello everyone. It's really lovely to be here. Thank you so much to IFIC and HSBN for having me. So I'm joining you from London, UK. So I saw there were some London, Canada people on the call, so it's nice to join you. So I'm a fellow at the Nuffield Trust, and I work mostly on social care and integration. And I'll be talking to you today about integration in England, and sharing some reflections as well about kind of 20 years worth of integration of health and social care in England and the UK, and it's been a very long-standing policy intention. Thank you very much. So to talk to you a little bit briefly about how health and social care are organised in England. So health and long-term care services, or social care in England, are distinct, and they're subject to very different funding arrangements and accountabilities. So on the one hand, we have the National Health Service, through which all health services are delivered free at the point of use. And then kind of in parallel, we have long-term care services, which are subject to eligibility and means testing, and they're the responsibility of local authorities, and they're accountable to the local electorate. And so most health services are commissioned and planned at the level of integrated care systems, and these were formalised in 2022 and given a statutory basis. So local authorities do have a membership on ICS boards, on integrated care systems, but the ICSs themselves don't have social care responsibilities. So that kind of creates this little tension really between the kind of two parallel sides of the health and care system. And while the intention of the ICSs has been in part to improve the join up of local authorities and health services, these have largely ended up in as NHS integration bodies, so have been much more focused potentially around integrating better services between community and acute, for instance. So these current arrangements are really in their infancy, but there have been some early improvements. So for instance, around hospital discharge, which was a major focus in many areas of England. And worth noting as well that as part of this structure that we have at a kind of sub ICS level, we have place-based partnerships, which are local areas. So local areas have the flexibility to develop and shape according to their local priorities, as well as health and wellbeing boards, which align with local authority footprints. And just to give you an idea of scale, so our integrated care systems manage populations of about 1 to 2 million people, and place-based partnerships manage populations of about up to 100,000 people. So kind of a much smaller scale. If we move on to the next slide, I thought I'd share some of the learning and the reflections that we've had based on kind of 20 years worth of integration initiatives. And these reflections have come from research that we did that was published in 2021, and I can post the link in the chat if you're interested. This looks at 20 years worth of policies in England, and as well as the other countries of the UK, so Wales, Scotland and Northern Ireland, and the outcomes that these have sought to achieve. So perhaps we can as well talk in the discussion about some of the natural experiments of the UK, where we have 4 countries that operate very, very similar, but also quite different health and social care arrangements, and some of the learning that's come from this. So to start, I think a lot of the integration policy in England and across the UK has been set at a national level, so with some very top-down levers to support integration. So these have included things like pooling budgets, having structural reorganisations such as the development of the ICSs, as well as transformational funding. And I think while those have been able to deliver some improvements to joined up services at a local level, perhaps some of the levers that have been drawn upon have been a bit disjointed with what integration has been set out to achieve in policy. So a lot of national policy has had the expectation of improving population outcomes, creating efficiencies in savings, etc. And perhaps the levers that integration has enabled have perhaps not been quite so joined up with that. And I think that really lines up with what Stephanie was saying around the lack of a logic model around integration. Secondly, I think there's been an assumption at a national level that structural changes alone will be sufficient to overcome existing barriers, but the cultures are very different. So I was telling you a little bit about those 2 parallel systems between health and social care or long-term care, and those accountabilities really are quite different. So local authorities are accountable to the electorate. They have to balance their budgets every year. The NHS is quite different to that, and it's accountable to NHS England. So it's the context in which they operate really vary quite considerably, and the structures on their own have not been sufficient to kind of address these cultural challenges. Then I think within ICSs, I think it's fair to say that in many cases, acute hospital trusts have still dominated, and it's been very difficult to shift funding flows away from the acute towards community health and social care, and especially in kind of current contexts of very high demand and pressure on across the entire system. And I think that's really limited the potential of the potential benefits of integration initiatives, although there has been some more recent success, for instance, around hospital discharge pathways. And I think it's quite interesting that so one of the countries that we've looked at across the UK, Scotland, were intending to reform their integrated care structures to reintegrate around community and health and social care specifically, and remove almost acute from the equation. These plans have been delayed, and I think it's quite interesting because really is that not just moving the decision about where the funding flows goes to more of a national level, so perhaps removing some of that local decision making. And then I think finally, one of the really big challenges that we've had about assessing the benefits of integration in England and the UK is that we've really struggled to measure the benefits of integrated care. So footprints have changed. So Stephanie referred to things like the vanguards and integrated care pioneers, which we've had kind of overlapping over a very short period of time. And I think the outcomes that national policymakers have hoped that integration can achieve are very difficult to quantify. In some cases, the data doesn't exist, or it doesn't exist in a way that we can really compare. against counterfactual. You can't exclude confounders, so just natural improvements to population well-being. And I think as well, a really interesting thing that we found is that in some cases, integration might lead to some improvements, so identifying unmet need, but that might not necessarily lead to cost efficiencies because in fact, you're identifying a new population of people that were previously underserved. So I think it comes back to that point about having realistic objectives about what integration can achieve. So yeah, lots to discuss here on England's experience and the UK's as well, but I'll hand over to Victoria, who I think is our next speaker. Thank you.
Thanks, Camille, and thank you, IFIC Canada, for inviting me as well. I'm saying hello from Vienna, Austria. And so I will be speaking about two countries that I've worked in a lot because Austria really is very backward in integrated care. So I wanted to zoom out, first of all, because obviously integrated care has been going on for a long year. And 2 years ago, we asked some of our key contributors to the International Journal for Integrated Care and the Foundation to actually reflect in their own home countries on what has happened over the last decade. And also to answer some of the questions that I've seen in the chat, how much guidance do you need on the policy level and how much needs to come from the bottom up? I think what we really saw in this comparison was that it doesn't seem to matter really, because when you compare countries like the Netherlands or Australia and New Zealand, where there have been maybe 1 to 3 to 5 policy reforms over a 10-year period, while in Canada, with all your different provinces and regions, you've had hundreds of policy papers, strategies, reforms, frameworks going on. The outcome really seems to be very similar in that, yes, we're moving 1 step forward and maybe 2 steps back, but this chasm between policy and practice is still something that all of us are struggling with. Next slide, please. And it's a really good example when we take the Netherlands, who's been one of the innovators over the past 20 years, definitely. And a lot has been going on, even though they only had 3 reforms really over the past 20 years. There is a strong commitment throughout the health and care system, throughout actually also government, that health, positive health, population health management, social determinants of health are really on the top of the agenda, which is really quite special compared to other countries. So there is a big awareness that we need to shift the focus from disease to health, and also then shift the way we organize systems and also organize processes. There's also been a lot going on, as also Stephanie pointed out, in trying out different funding models, bundled payments, etc. And a lot of knowledge has been acquired. One of the key learnings from the Netherlands is that they've always managed to actually evaluate everything they did. They are very thorough in analyzing, in learning lessons, and then also disregarding what hasn't worked and learning from it. But when you ask colleagues from the Netherlands, they will also say, well, actually, we're still a very fragmented system, and integrated care is really still more an aspiration than a fact. 2 really new developments, which are now starting to actually be implemented in practice, are really a case in point. There are 2 policies. One of them is the Integrated Care Agreement, and one is the Healthy and Active Living Agreement. They're seen as 2 parts of the same initiative, but they again show how policy and practice really don't seem to fit together, because these policies, the Integrated Care Agreement is very much focusing on primary and secondary care and setting up integrated care regions similar to what the England and Scotland have done and what some of the Spanish countries have done as well. They're driven and paid for by the health insurance system mostly. So it's still, even though it's about data sharing, it's about learning from each other and establishing integrated care networks, it's still very much disease driven. While the Healthy and Active Living Agreement is all about prevention, it's all about health promotion, and that is driven by communities and municipalities. So you are building up, you have 2 parallel policies driven by different stakeholders in the system, asking for those different stakeholders to actually work together across both policies, and none of them really knowing what they're doing. Next slide, please. And that is really, I think, the case that we can see and learn from, that we see a lot of really good policy and intentions. But then when it actually comes to implementation, there is a real, there's a real misunderstanding and a missed opportunity of actually giving the freedom for local initiatives and regions to figure it out for themselves. Usually policies are much too restrictive in actually saying this is what you need to do, rather than saying these are our aims, this is our vision, these are the outcomes we want you to reach, now figure it out for your local communities, for your populations. There's also clearly a huge lack of actual knowledge. What does implementation mean? What does change management mean? And what does it mean on the different levels of the system? It doesn't suffice to say we mandate that a university needs to evaluate and work alongside an implementation strategy. There needs to be really also investment into the knowledge of the implementers on the ground, the frontline workers, but also on the systems level. And so that is something that we found over the past 3 years working in the Netherlands on an implementation model, that really the knowledge on what actually is going on in the system, who are my key players, and how do I actually also bring those people together, is really non-existent. And it's one of the key barriers to change for it to actually happen. And then something that has come up now in my conversations with colleagues from the Netherlands, when we were reflecting what are the lessons over the past 5 years in these implementation models that we tried to support as well as academic partners, and where we saw that actually everything that we've told them did not, well, it did happen, but they didn't really listen to what we said the lessons learned from other countries were. So the question really is, why are we so obsessed with transferability and scalability and comparing outcomes when clearly everybody just does what they want to do? And how do we actually get people not only to listen to evidence and lessons from other countries or even other sites, neighboring municipalities, but then actually also acting on it? And I think one of the key questions here is, what is it that people need to learn themselves and experience themselves? And a lot of change and a lot of implementation is just feeling the pain and going through the process. So I would challenge this question also in, yes, we need those policies, but how much can we actually learn from others? And what is it that we need to learn ourselves on the front line? Because finally, what it really is about is that we need people who are humble, who are resilient, who are courageous in really breaking out of those known norms, walls, and processes, and really thinking about a very different kind of system. And that is something that we as academics, I think, also face a lot, that it's a challenge to really break out of what we know and think outside of the box, which is very much implementing a learning system. And that is probably one of the key lessons also for policymakers, that we need to move away from mandating and more towards a really implementing learning health systems on a reasonable scale around regions, around communities, and around populations. And with that, I want to hand back. Thank you.
Lovely. What a really interesting set of reviews, of comments and thoughts, both from the North American Observatory study, as well as Camille and Victoria. I might take down the slides here so we have a little bit of a conversation here for a few moments. Fiona Line is celebrating in, and we could come to just those people, if we can highlight Victoria, Camille, myself, Stephanie, if you can come off mic and come back, I think, to a few of the comments that were raised in the chat, and I think also touched upon. I think actually everything that was in the chat was also touched upon. I'd like to thank Leah for noting around this national data strategy. I wasn't aware of that but I certainly look forward to creating that opportunity. And so one of those areas was around this notion of data sharing, and in Europe they have the GDPR, which is actually created, as you indicated in the chat, meant to make it easier, but people have a fear. And I think here, oftentimes data sharing agreements and getting to all of those is a challenge, not only for the evaluation purposes, frankly, that's the space I work in mostly, but the challenges of sharing information at the front lines in order to enable care delivery, not just to enable evaluation. And I just wonder if there have been policy supports or some countries that have done a better job internally of trying to create those opportunities at the front lines to enable data sharing across organizations. So maybe I'll first ask Stephanie in your review, and then Camille and Victoria, if there was anything around that you found from particular countries that might be insightful.
In terms of data sharing specifically for
policies to support data sharing.
Yeah,
because here I think many times the providers would say we can't. There's a policy that prevents that often.
Yeah, unfortunately, the data sharing and use was quite a limited. It was often quite limited, and a lot of our findings and informants didn't have glowing things to say about their capacity to share things. One thing that did come up, though, was that often, while there was quite a bit, many of the evaluators from the different evaluations and projects, so that GDPR really did impede their ability to do any sort of analysis of primary data from the electronic medical records. But they did say that a lot at the provider level between primary, secondary, and community care there was the ability to pull out data records and to be able to create better coordination and care plans for the individuals actually needing better coordination of care. But I actually think that maybe I should pass this over to Camille and to Victoria, because they might be able to provide a bit more detail at a more granular level than on the high level, because it was quite it wasn't an overwhelmingly positive reaction from our evaluation, unfortunately.
So Camille, how are we going to do with the ICBs and the ICSs in the UK?
I mean, I think it's a very tangible challenge, I think, for many of the ICS ICBs to deal with at the moment. I think some have been in a better position than others, just because of the existing systems that they started working with were already kind of somewhat more aligned. Others have been, I think, much more challenged. It's been a lot of work in developing things like shared data records, health and care records, and doing things like co-locating people working across health and long-term care to be able to see or to share information. But I was recently in the northeast of England looking at a discharge hub, and it was really interesting because there were people who were working as part of the discharge service who had two different computers, one which spoke the health systems language, one which spoke the long-term care language, because the systems weren't the same, and they had to manually copy from one computer to the other the information about each of the individual people that were coming out of hospital. So I think we talk about some of the challenges of data sharing, but before that there's some really fundamental infrastructure challenges, which I think at a granular level are really quite varied and really very much I think a product of many years of embedding different systems across different areas and then having to kind of undo that or work together to overcome them. So I think there's some positives, and I can share a little piece of work that we did over the summer about some of the improvements, for instance, around discharge, which is kind of one of the more tangible examples, but maybe Victoria has some more positive things to say. I don't know.
Well, I don't know about that. But I think we need to keep in mind innovation and change happen in our current systems. So because if we didn't change, if we didn't think that we needed change, then nothing would ever happen. So we are actually, those initiatives that are successful find workarounds and they find solutions to our current challenges, and then only by pushing them, then come up with new solutions. And some of them are about data sharing. But I do think that I think very often when these are seen as barriers, it's just an excuse to not actually integrate and not talk to each other. Because I love the example from Catalonia, where they've had for the longest time, as almost everywhere in the world, you had your separate health system data and your social system data. And when they started integrating on the local level, they knew that would be a challenge, especially also because it was legally it was prohibited for primary healthcare to actually share data with social workers. So what did they do? They actually, the doctor opened their data set, and the social worker sat beside them and opened their data set. And they just looked at both of the data sets for one person and then looked at that. And that's how they had a workaround. And by also then showing that it actually has merit, they now have a legislation that allows for shared data sets, and they actually have, they're building up an integrated health and social care data set at the moment. So I think that a lot of those challenges are just with the GDPR, that is also mentioned in Stephanie's policy report. Yes, data protection is important, but when you read through the fine print, then you can always use it if it's to the benefit of a population, if it's for academic uses, if it's for research. So if that is used and is used to not share data, it usually is just a lame excuse that we actually don't want to collaborate anyway.
Thank you. I have also seen people find ways to make things happen, and people hiding behind who maybe, I don't know, less willing to make that happen. I'm conscious. I know that we have a fair bit of info still to come, but I do want to ask one more question. I'm going to park the one which is possibly one of my preferred questions around came from Carolyn Steele-Gray, standards and local flexibility. And I'm going to ask one about implementation supports. And so, Victoria, you both mentioned, why are we trying to standardize everything anyways? It's all local. But you do also talk about a real gap, and the NAO report also talks about that, of policy supporting intention to implementation, and you talk about a lack of that support and gaps. So maybe I could ask everybody in like 1 minute, just to summarize 1 or 2 thoughts on what supports you think can be made available from more centrally located, be it agencies or health systems themselves, towards local providers to support integrated care around the implementation of these models. Are there key roles? Are there key activities, key supports? I'll go backwards this time, Victoria, Camille, and any up with Stephanie.
Sure. Yeah, I think this idea of whether it's a policy entrepreneur or a knowledge broker or some such thing, but a role where that a person who actually knows how the system works, who the key stakeholders are, how we can approach those stakeholders, and also what the different levels, roles, and responsibilities are, and how to bring people together. I think that would be hugely helpful in implementation support, as an implementation support, to really take off the pressure from local implementers to actually go out and find out how the system actually works.
Yeah, I'd completely agree with that. I think from our findings and from our kind of experience of integrated care initiatives, where there's been transformational funding that has enabled kind of granular support, and I think kind of helping that kind of sharing of vision and that sharing of language has been really beneficial, and kind of building up kind of from the bottom up a shared kind of culture and vision, I think. But it really comes down to an individual or a group of individuals that kind of have that leadership in creating that space.
Okay, finally, Stephanie.
I also have to very much agree with Victoria and Camille that often a lot of what we do see and what people praise in all contexts is that capacity and that stability to have somebody who is, say, a contract manager who really knows what the intention of the policy is, because often, and also previously in my experience, having been involved with some of the integrated care pilot evaluations, you'd often go to a field site and people would say, we've been given this legislation, we've been told to do it, we're opening the envelope, and we just are trying to do our very best to say, how do we do this legislation? So while there needs to be this room for this local adaptability, it's also really important to have that contract manager, that those dedicated funds for one person to really be able to sit down and figure out what does this look like in the best possible sense, so that they can very thoughtfully and coherently think about how to move forward with integration of care as this end goal, rather than just trying to do an exercise quite quickly to check a box and, you know, to really achieve this meaningful integration between the sectors.
Can I just add in
Yeah.
something quickly?
Yeah.
That's okay. I think something that's I'm seeing more and more in England is the use of potentially like independent or external advocates who kind of come in and help facilitate that discussion and kind of really break things down into where are the barriers, who needs to be involved, how do we facilitate this conversation, how do we use our resources most efficiently. And I think kind of having that independence of someone coming in and creating that conversation and taking away some of the kind of previous cultural barriers has been quite beneficial. I mean, it's quite costly, but I think it's a worthy investment, I think, in the long term.
Yeah, that's actually what I was thinking of is I know there's a similar project. There are these specialty project managers that get catapulted in. They've done it well one place and they know where the areas and the barriers may be, and they're able to really draw people together. And that's such a costly but very helpful, very integral facilitator.
I think that facilitation role is quite key and important. We've learned of this right at the practice level in primary care teams, but also at this meso level. I was talking to some trainees a couple of weeks ago, and they asked about where the gaps were, and I said facilitation. We really need more people who are able to play these roles. I think, thank you so much for a lot of so much insight here. And we've seen a lot of different examples of supports that we can maybe bring into the discussions in the upcoming community events. I'm going to come back to a poll for the audience now, for the participants here today, because we certainly see a number of tensions, I think, arising here. And so I wonder, from the participants' perspective, there are some policy tensions that I think come to bear here, and I wonder what you think might be important ones. One is this idea of balancing local innovation and system standards. Another is on this idea of the focus on integrated care at the front lines versus integrated funding, enabling that. Another is actually, how do we develop the resources around this of funding with new money versus that call for savings. And finally, having the sufficient local levers to enact change, which are sometimes just locally developed, but might also require some policy attachment to this. So maybe click in to see if there are others, please add them into the chat around some of the tensions that you might see and which ones you think resonate for you based on some of this discussion. These are some of the ones that I thought resonated for me, and I'm just interested in seeing what some of our participants, which ones are resonating for them around these topics and ideas. So we'll leave it up because there are a few different options, people to read through. People are still chiming in, so and we're almost going to head in now to understanding some of the examples in Ontario as a Canadian example. I see also some other pieces, time, yes, competing priorities and time, needing for a longer vision of cycle versus political cycles of short term, which might actually get into some of the policy, you know, how Canada has many policies. I think it's a policy of incrementalism, as opposed to being willing to kind of take that big shift and put forward a larger policy. And so why don't we share out these results here? And I think there's resonance across all of these. They're all fairly highly rated here in terms of those pieces. So I think all of the messages here, what this tells me that we've heard from our international experience today, are resonating with the participants today in their local experience, as well as these others that are coming into the chat. Really, really great to see. I'm going to turn over now. Thanks so much for participating so far to an Ontario example, and I'm going to ask Dr. Guillaume Boldania, a longtime collaborator with HSPN, to talk about some of her findings from the team as we looked at this in the Ontario at a granular level at the front lines through a number of interviews. Gaia, let's turn it over to you.
Thanks, Walter. Hi, everyone. So I'll be talking about the gap between those guiding programs from a system level and those implementing programs on the ground, and how this gap may be bridged from an Ontario perspective. Next slide. So an overview here of the rest of the presentation. I'll just bring your attention to the 4 themes under the results piece there, and that's going to be guiding the bulk of this presentation. Next slide. Okay, so this is just a bit of context for those outside Ontario. So Ontario Health Teams were introduced back in 2019 by the Ministry of Health. And these are organizations and providers working across sectors to provide coordinated care in a clinically and fiscally accountable way for a defined geographical population. And the goal is for every Ontarian to eventually belong to one. And currently, I believe there are 58 OHTs. So we at HSBN have really been evaluating the progress of this initiative in various forms. And this slide simply provides an overview of a developmental evaluation we recently conducted with OHTs. The first column you see here lists areas that were being prioritized by these teams, and progress in these areas were then associated with what you see in the second column. So things like trust, shared values, making time for sense making, alignment across sectors, distributed leadership, communication, and so on. So OHT development was certainly frustrated by the absence of the things listed in the second column here, but one of the things that kept coming up was the impact that the system and policy context had on team development. And that's what you see in the third column. So participants talked about how progress was frustrated by changing accountability and reporting structures, conflicting information, a dearth of long-term direction, pre-existing system constraints, and this impacted things like data sharing and long-term funding. And there sometimes seemed to be misalignment as well between OHT and provincial priorities. So given the prominence of this theme, we thought it worthwhile to explore it further. So that's essentially what we ended up doing. But this time we wanted to include the perspectives of those from the system and policy side of things as well, just to see if we could try and maybe intervene and bridge gaps in some way. Next slide. Thank you. So our purpose was threefold. So first, it was to understand what OHT participants found challenging about the system and policy environment. Secondly, we wanted to look at how system-level participants responded to these challenges. And lastly, we wanted to understand what the perspectives and concerns of system-level participants themselves were as it related to OHT implementation. Next slide. So we collected data from November 2022 to February 2023, and the data are probably important because things have significantly changed since then on the policy end of things. And this involved interviewing 18 participants from both the system and OHTs. The 10 system participants included people from the ministry and from OH, which is the Crown agency responsible for the administration of Ontario's healthcare system. The cross-boundary stakeholders were people who didn't identify with either category or perhaps cross both in some way. So the questions we asked were guided by things that we had learned during the developmentalist evaluation, as well as a symposium and a webinar that was held soon after. So interviews were transcribed, thematically coded, and then analyzed. Next slide, and next slide again. So moving on to results. So OHTs felt that there was a lack of direction which affected their ability to confidently move ahead. So this affected everything from governance, digital initiatives, coordination with home and community care to performance measurement. The system stakeholders were a little bit calmer. It was evident that they had a much deeper understanding of end state vision. They knew about plans to streamline communication, to track funding envelopes, things like that. They knew exactly how the various provincial committees and the working groups related to each other, and so on. System stakeholders were also concerned that OHTs did not really have a good understanding of the learning and capacity building that was needed to develop as an OHT. And they weren't sure if OHTs truly understood things like the range of things that home and community care services does, how to make primary care a cornerstone of the OHT model without necessarily letting it drive everything. How to use population-level data packages to harness the performance measurements expertise that was already available to these teams. And even, in some cases, how to actually successfully interpret and respond to a funding call. And so system stakeholders thought it was more important for OHTs to figure certain things out, rather than waiting for an instruction sheet to be given to them from above. Now, having said that, system stakeholders were also very concerned that they were unable to tell OHTs how to get to the end state. But they felt that this was somehow beyond their control. There was a bit of a tendency to see themselves as bureaucrats with little power to truly change things. It was up to the government and political will to enact change, or so they thought. So there was a sudden deferral of authority. Next slide. Okay, so here you have some quotes. So first from the OHT perspective and then from the system and policy perspective. So here's someone from an OHT saying, they, the ministry, were every OHT, you decide on your own governance model. And you know what? It's a mess. They now think they've landed on a solution, which is incorporation. It's like saying, yes, you need a house. Great. How many bedrooms? How many bathrooms? How many floors? How big? How small? What's in it? What's not in it? It is a shell. To which the system stakeholders respond, you're trying to nudge Jello along. Simply moving all of the levers to the OHTs is not going to do anything. And I know that people on the front line of planning and delivery are like, you just described a nightmare to me because you've given me no clarity. But there's no shortcut by saying, I'm giving you this and that will make everything else happen. And someone else says, you haven't committed all of the steps of the maturity vision, and that is what keeps me up at night. And that inability to be very transparent about that is to be expected, because if you set out every step of the way out of the very mature vision, there are some very hard policy decisions to be made, very big things to move. And I don't think that there's yet comfort in taking those steps. Next slide. Okay. So now when guidance was provided, of course, it wasn't universally welcome. The standardized provincial expectations could not account for local specificities, perhaps particularly so for Indigenous teams or teams in rural areas. There was also some pushback on secret measures, so these are the quality improvement measures, as well as guidance on governance. So essentially, OHTs wanted an approach to population health management that accounted for a difference. Now, system stakeholders, for their part, were keenly aware of the need to provide guidance while somehow allowing for local flavor. They were also wondering how equity fit into this piece. So for instance, would treating certain OHTs and populations differently compromise equity? Would it enhance equity? Right, so now system participants also had a very different understanding of the quality improvement indicators and what they represented. So they saw them as a way for the province to signal to OHTs what they saw as important, as well as perhaps for a way for OHTs to identify what needed to be changed, but certainly not as judgment, which is probably how the OHTs saw things. Next slide. So you see here an OHT participant saying, some of the secret measures we found were probably a lot hospital focused, so the ALC stuff, etc. I'm just surprised they didn't get more granular in terms of like, this is what's in your catchment area that you should be focusing on. Someone else says, we're very grounded in our 7 grandfather teachings. We knew we wanted to be highly Indigenous led in our leadership principles, so that's not going to come about by way of a provincial template. To which the system stakeholders respond, we do want OHTs to take a population health management approach, which means by default, there is a localness to it, a specificity to their own population. But at the same time, there will never not be provincial priorities for the health system. So I think that there is a tension that remains, and we will have to find a way to manage that tension. Someone else says the indicators were a way to start signaling our expectations for OHTs. It wasn't that we would expect an OHT to be able to have all these levers to drive the changes, but the members need to look around and say, oh, this is a system priority. Am I pulling my weight here? So it's a really important signaling exercise. Next slide. So okay, we need adequate sustained funding to make a difference. So this was, of course, before the announcement of multi-year funding was made. But it was at a time the OHTs had already been working with lots of annual funding that was buttressed by various smaller funding pockets. Now, this seemed to affect staff retention, perhaps most of all. So system participants, for their part, they wanted OHTs to focus on value-based care. So they thought that true sustainability came when funds were not externally provided, but rather generated from within through integration. The OHTs would likely say that in order to get there, they needed to have close loop control over their funding, and this was yet to happen. And they would say that they perhaps needed an injection of sustained funds to help them navigate the early admin work needed to allow this to happen. Now, interestingly, the two participants who did not identify with either the OHTs or the system, they thought that funding should be taken out of the equation entirely. They thought the focus should be on integration itself and providing tailored guidance and resources to help OHTs address whatever it was that stood in the way of integration. Next slide. Okay, so here's an OHT saying, I feel like these people that I've hired are like unicorns that wake up every single day and dedicate their whole life to progressing this model and working with our partners. And they've developed this trust and this relationship. And I'm terrified that because they don't know whether or not they have a job in August, that of course they would leave. On the right, you hear someone from the system responding, the teams have to extract value back out of the system. We probably have to enable that to happen in certain ways. But I think that there are a handful of teams that say this is worth so much that even if the ministry stopped funding us, we'll still find a way to continue this work. I like that attitude a lot. And someone in the middle, this is an alternative perspective, someone who doesn't believe, rather belong in either of these boxes, saying, take money off the table. Focus on integration. The government thinks it's all about money. It should be about integration and then investing where integration is not happening. Similarly, every single conversation with healthcare providers begins with two words, more funding, instead of what are the steps that are necessary to achieve integration and where can we invest in those steps to affect change? Is it you don't have equipment? Is it you don't have enough beds in your hospital, and so on? Next slide. So OHT participants were not clear about the roles of certain system participants and the relationships between the various system players. So for example, what was the role of OH regions versus OH corporate? What did relationship managers actually do? Why were there so many layers? Why did there seem to be so much overlap between what some system stakeholders were doing and what OHTs themselves were doing? The system participants were much more tolerant of this uncertainty because for them it didn't quite exist in the same way. They understood their roles, they understood how their roles related to each other, and they basically just wanted OHTs to have patience with the evolution underway. System participants also thought that the value of system partners is not fully recognized. So they felt that some in OHT world felt that they were perhaps even in competition with OH because they didn't fully understand everything that OH regions did or what certain roles potentially could offer. System stakeholders also knew that certain OHTs, the ones chosen as pilot sites for various things, for instance, would have a closer relationship with system stakeholders than others. So basically knowledge was not necessarily uniform across teams. Next slide. Okay, so here's an OHT participant saying, I asked the OH clinical population specific lead to come to the OHT and present. And when they did, it was a kerfuffle, of course, because everyone's like, what? All this work is happening? What is our role? If that's your role to develop all the pathways and all these things, what the heck are we doing here? And someone else says, we got rid of the lens and now we've created OH. I don't understand the need for the layers. Give them the role of OHT executive lead and we'll go back to our desks. It just seems like we have positions that are funded by OH through our funding. And system participants respond, because this OH wasn't a pilot site or a leading project site for either of the two pathways that have already rolled out, they just hear it differently. They're not aware that, oh, okay, this is already happening. Someone else says, in an ideal state, they see their OH regional counterparts as sources of regional expertise, as allies in their entryway to OH, and as a really positive source of information and brokering across OHTs. OHTs have maybe an unrealistic expectation of the level of admin and control they could have at the scale that they currently exist. Next slide. Okay, so here's some of the things that we glean from all of this. So OHT participants seem to be prioritizing local concerns over those of the health system. They tended to see themselves as separate from or in competition with the system, and sometimes they lacked an understanding of the limits of their own capacity and knowledge. As for system and policy participants, they were familiar actually with OHT concerns, but they were unable to respond freely and share their own concerns. And this could lead to OHT participants feeling like their system counterparts were divorced from on-the-ground concerns. They also seemed somewhat unaware that the motive behind chosen performance measures had been actually misunderstood by many, and that it was not enough for system-level stakeholders alone to know about future state. They also expected OHTs to understand the importance of identifying and filling knowledge gaps and generating value from within without reiterating this need, without guiding the work required to get there. And they also lacked an understanding of the need to demonstrate the value of system structures and roles to OHTs. Next slide. So these are some recommendations for OHTs. It'll be followed in the next slide by recommendations for system stakeholders. So perhaps they could, OHTs could develop an understanding of system level priorities and pilot initiatives, the rationale for why these priorities are actually prioritized. Perhaps they could develop an understanding of system level structures and roles. So the responsibilities and role scope of OH corporate versus OH regions. What are some available supports, system level planning tables? What are central program of supports that's available? What are communities of practice that they can perhaps take advantage of? Secondly, they might want to reconceptualize the relationship with the system from one of competition to cooperation. And one way to do this might be to invite OH representatives to OHT tables where possible. And they could develop a reflexive understanding of the limits of their own knowledge and capacity and develop a plan to address these gaps, possibly by tapping into already available supports where possible. Next slide. So recommendations for system stakeholders. Okay, so start perhaps with building trust through communication and transparency with OHTs. To share plans where possible to mitigate OHT anxieties and as a reminder of end-state vision. Share information on how existing planning tables may inform OHT level work. Build even relationships with OHTs so that those that are not pilot sites don't feel left behind. And set clear expectations for what the system expects of OHTs and what OHTs can expect of the system. So reiterate expectations of value generation, clarify the purpose and the planned evolution of quality improvement indicators. Thirdly, demonstrate the value of system-level structures, supports, and roles to mitigate confusion about responsibilities. And again, encourage the meaningful embedding of OH at OHT tables. Fourth, work with OHTs to identify and address gaps in knowledge and capacity. Monitor the needs of OHTs with contextual factors that affect capacity building, things like being an indigenous or rural OHTs, and this can be part of an equity-driven approach. And finally, establish or endorse common supports that OHTs can systematically draw upon with confidence that they do in fact have system approval and cross OHT applicability, so they won't be expected to change the way they're doing things, 4 to 5 months down the line. Next slide. Okay, that's probably enough of me holding forth. Over to you, Walter.
Oh, you might not be entirely out of that seat yet, Kaya.
Okay,
We'll
that's
see
nice.
what kind of questions and comments might be coming in here and thoughts. And I'm actually going to kind of also come back to our earlier speakers a little bit. I think one of the key pieces that strikes me, I mean, there are many findings here from various perspectives, but one of them seems to rely on the value of improved communication and the extent to which this is enabled. So I don't know if there are places in your interviews where people seem to talk about where communication had gone well, some opportunities to leverage, and or if you don't remember any of those, some of the more poignant points around the challenges in communication between frontline implementation and policy.
Yeah, so it's interesting. When you dig into the literature, there is a lot of stuff about communication as it relates to this. So, there's a gap in communication because policymakers, system stakeholders haven't appropriately, effectively communicated things to the people who need to use this knowledge. But really, this is not just about communication. It goes a bit deeper than that, isn't it? It's a translation, really. And it's also a learning, right? So there is an assumption that everyone is on the same page, and therefore there isn't a translation happening between, this is why A, B, C, and D are priorities, and this is why you two should be affected by this, and this is why you should work towards them being priorities to you as well. And then there's also the learning thing, right? Because in some cases, this takes the learning health system piece to a whole different levels, because policymakers, system stakeholders also are very much trying to learn from what's happening on the ground, and hence you have these pilot initiatives. But it's a little bit frustrating for those actually, engaged in these pilot initiatives, because they feel like everything's a little bit wibbly wobbly, right? And it's just shifting sands, and they just want something solid to latch onto. So it's a little bit of a give and take, because the policymakers want to learn from what's happening on the ground, and there's this push about but tell us what to do, but we want to learn from you. So there is an interesting, it is positive. It's good that this learning is happening, but a bit more structure within that receptivity would probably be appreciated from those on the ground.
Yeah, I have to say, we're trying to support through Canada initiatives across the country that are aiming to support integrated care initiatives, and we're trying to learn internationally. But I think that this, I always like to almost feel like it's an easier spot for us sometimes to try and identify and bring the stories to life. And I'm not sure I'd want to be the policymaker trying to trade off these tensions of being too prescriptive versus not enough, or the front lines taking advantage of some open space versus waiting for some guidance. I think I have empathy to all sides and all perspectives in this work. I just before closing out today, I think I'd like to come back to Stephanie and Victoria and Camille, and you may have a perspective on this. And I was looking back to the international examples, and I just want to validate a bit of a consideration that I have. I think what I'm hearing is, and have heard before, is that there isn't a single right way, that we want to learn from each other, and some of those examples that have worked out well. I mean, if I look at it in England, coming back to the summary from the NAO, that seems to be a bit more legislative in its approach. I believe the Black Forest and Kensington take advantage of special funding operations. The way I hear about the Netherlands is there's a lot of experimentation opportunities, and then accountable care in the United States is really a business model. And you can think about these as maybe even being culturally representative of where they each come from. So I wonder if our participants in the audience have a perspective on Canada of where you think we fit from being more legislative, creating special funds, trying in different experimentations, or whether a business model might apply, or whether there's actually an entirely different way forward for Canada. But I do think that there wasn't a one size fits all. Do you think that there was a particularly advantageous approach? I guess, Stephanie, I'm going to ask you first, because I kind of cited those out of one of your summary slides.
I'm really sorry, Walter, could you just repeat that, please? Yeah,
if I look to the different countries that we've looked at and talked about in a bit more depth today, of England, Germany, Netherlands, and the ACOs in the United States, I see the different approaches to policy being more legislative, creating special funding opportunities, spurring on experimentation, or having a business model approach. And if Ontario doesn't have any one of these exact models, is there one of those that you think offers more advantage, or do you think that there's a special case for Ontario and Canada with its multiple provinces doing things differently, or can we lean on some of these other experiments?
Yeah, that's a great question. I think that we do see a wide range. I think often we look towards the UK the most because of its similarities in terms of its system and its health insurance system being like free at the point of use, which is most similar to the provinces here. I think that what we do see that is successful is having the national level apparatus of where the direction of policy is, but there's been a real distinct turn towards moving away from, similar to what Guy said, away from this area of competition, more towards collaboration and setting up the framework for local capacities and local abilities to have some room for adaptation to really create the most have the best possible setup to start integration projects. I think we see a lot of the legislative supports have been particularly helpful in the UK context in setting out what the direction of travel will be and really enable and to say, you know, we're not going to have a series of different reforms or shakeups to the system, but we're going to very consciously look towards collaboration between sectors being the direction of policy and giving people the freedom and capacity as much as possible, given the limits of other political flux, to proceed. However, and that being said, I think there's also some really interesting local experimentation that happens in the Netherlands that's very specific and localized. And I think if we can find some way to bridge those two together, I think that it might be there's some really interesting space for experimentation that we can draw policy lessons to have positive supports from there.
Thank you. And we're almost at time, so we're just going to close out now. Sorry, Victoria and Camille, we're not going to come back to you. I think Jim resonates with, I think, what you were saying there, Stephanie Jimbo-Shiko, around being experimental and engaged in creating a more prescriptive or guidance, I would suggest, approaches after evaluation around how we can see some of these pieces. And I think we've seen that through some specific experiments previously in Ontario, through the integrated funding models, pilot programs, and bundled care. And I think in Quebec, they have also seen things through the PRISMA and SIPA programs, where they then, you know, legislated and supported local adaptations of those experimental programs. I think it's created great opportunities. I'm just going to come back now to a poll of everyone participating today. If we can launch this, just to see if you've learned today, if it's been a good use of your time. After the webinar, how knowledgeable, need a lot more information, somewhat knowledgeable, or whether you're actually now moving up to the area of feeling actually a little bit more knowledgeable and comfortable with what's happening elsewhere in the world. You know, we are often saying that everybody else has this solved. I think we're learning a little bit that they don't, but they're experimenting and trying out different things, and maybe we can grow from those opportunities and that experience. So let us know a little bit about where you might place yourself now in terms of your knowledge about today's topics, not Toadie's topics. Looking at a little spelling error at the top of that one. And really appreciate everyone in joining today and participating in the chat. And the resources that we've collected in the chat will also be presented in the consolidated deck that we will post online. Let's share out these results now from those people who have keyed back in. And if I see clearly, you know, it was sort of spread about 20% in the first 5 columns earlier today. And now we see actually very few. In fact, I think you'd have to get to column 4 before you can cumulatively add up to 20%. So congratulations to our panel for bringing lots of new knowledge and insights to the participants today. I request and encourage you to either click on the link that's going to be in the chat or to scan this code now so that you can let us know. This is for signing up for the newsletter. We can go back, a little reminder to everybody in case you missed the dates at the beginning, the 15th to the 17th of October 2024. We are going to join hundreds of us together in person in Calgary to talk about this and many other related topics about community, creating health and well-being, supporting community and individuals. So just to close off now, last word in the chat from my colleague Jodine, the snowball, which is in one word, describe your experience being part of the virtual community today. Try that out. Let us know in the chat. It's a wonderful way to close out. One word, snowball. informed. Thank you, Miriam, for joining in. Let us know in the chat. Resourced, inspired, Jim. Happy to see. Walu, resourced. One word just to think about how you feel leaving here now. Hopeful, determined, seen and heard, Lindsay. Curious, relieved, not all alone, enlightened, Mike. That is amazing to have that opportunity. Thank you all. Continue as your way out to enter your one word in the chat as you close out for the day. Thanks all. Really appreciate your being part of our event today. And we look forward to having the recordings posted for everybody.